In the previous video, we discussed how an index event led to an increase in inotropy, chronotropy, afterload, and preload. We discussed how an increase in a preload in a pathological manner for a prolonged period of time led to a sequence of events, which ultimately led to an increase in the radius of the cross-section of the left ventricle, causing left ventricular dilation. We discussed how the law of Laplace helped us to explain how this led to a progressive decline in the pumping capacity of the heart. We also discussed how this index event caused an increase in the activity of the SNS and the RAS, which led to a prolonged and sustained stimulation of beta-adrenergic receptors, AT1 receptors, and mineralocorticoid receptors. We discussed in detail how this caused pathological remodeling of the heart, and how this caused a progressive decline in the contractility of the heart. We discussed the clinical features as well, and how they progressed from the asymptomatic state to frank acute pulmonary edema in a state of, or in a process of, constant and steady decompensation. Now, prior to our current understanding of the pathophysiological models of heart failure, the principles of treatment of heart failure were based on two basic principles. Firstly, it involved the relief of symptoms produced due to congestion by the administration of diuretics. And secondly, they involved the induction of the heart to beat harder so as to drive the blood more forcefully from the ventricles. So this involved the use of positive inotropic drugs. Now, this is a diagram which we spent quite some time on in the previous discussions. So this represents the system, the circulatory system in a patient with full-blown heart failure. Now, if we administered diuretics to this patient, we would flush out the excessive fluid that is collected in the interstitial spaces, both in the pulmonary tissue and the peripheral tissues, and this would relieve congestive symptoms. Also, if we were to administer a positive inotropic drug, this would drive the blood more forcefully out of the ventricles, causing a reduction in the back pressure that is exerted on the pulmonary tissues in the case of the left ventricle. Also, when we administer the positive inotropic agent, it causes the right ventricle to pump harder, and therefore the back pressure on the systemic veins is reduced. So these were the basic principles of treatment of heart failure in the olden days. These drugs definitely provided acute symptomatic benefit. However, they failed to alter the progressive nature of the disease. They failed to reduce mortality. In fact, evidence has shown quite conclusively and convincingly that almost all positive inotropic agents reduce life expectancy when given chronically. Right. So, drugs for chronic heart failure should halt or at least delay the progression of the disease. They should increase life expectancy. And it has been found that drugs that reduce neurohormonal activity, namely the activity of the SNS and the RAS, these drugs have been found to achieve this goal. Now, which exactly are the drugs that we are talking about? They would include the ACE inhibitors, the beta blockers, the mineralocorticoid receptor antagonists, and the activators of the natriuretic peptide system. We will discuss about that in detail in the subsequent discussions. Now, some patients who are started on ACE inhibitors tend to develop cough and or angioedema, which the patient may not be able to tolerate. In such situations, the ACE inhibitor needs to be abandoned and replaced with an ARB, an angiotensin receptor blocker, instead. So when we discuss about the drugs used in heart failure, we commonly write ACE inhibitors / ARBs. So that simply means that if the patient can't tolerate an ACE inhibitor, we abandon it and we use an ARB instead. Right. So what would be the general approach to the management of a patient with chronic heart failure with reduced ejection fraction? Well, to begin with, we start the patient on an ACE inhibitor and a beta blocker. If the patient has got congestive symptoms, we add a loop diuretic. And if not contraindicated, we add a mineralocorticoid receptor antagonist. As we discussed earlier, if the patient develops a cough and or angioedema on the ACE inhibitor, we abandon the ACE inhibitor and we replace it with an ARB. Now, the beneficial effects of these drugs may take months to manifest. It may take up to 6 months to manifest. So if the patient is doing well with this treatment and if the blood pressure is within normal limits, the guidelines advise us to continue all these medications, but to withhold the ACE inhibitor or the ARB as the case may be. And then we wait for 36 hours while continuing the other medications, of course, and then we replace the ACE inhibitor or ARB with a drug called an angiotensin receptor blocker and neprilysin inhibitor. It's called an ARNI. We'll discuss more about that in the discussions to come. Okay, so if in spite of optimal treatment with these drugs that we just discussed, the patient still remains symptomatic, we have options. If our patient happens to be an African American, then we may add a fixed dose combination of hydralazine plus nitrate. Or we could abandon the ACE inhibitor or the ARB and replace it with the hydralazine plus nitrate combination. If in spite of the previous treatment we find that the patient remains symptomatic with a heart rate of more than 70 in spite of being on maximally tolerated dose of beta blocker, we may add a drug known as ivabradine. Again, if the patient remains symptomatic in spite of treatment with an ACE inhibitor or ARB, beta blocker, a loop diuretic and a mineralocorticoid receptor antagonist, patient still remains symptomatic, then it's probably time to consider the addition of digoxin. Okay, so now let's come to the ACE inhibitors. What happens when we administer an ACE inhibitor to a patient with chronic heart failure with reduced ejection fraction? Obviously, when we administer an ACE inhibitor, it inhibits the conversion of angiotensin 1 to angiotensin 2. The plasma concentration of angiotensin 2 falls, and therefore the stimulation of AT1 receptors is reduced. Now, let us try to put together everything that we had discussed in the previous discussions and try to understand how an ACE inhibitor works in heart failure. Now, we discussed regarding the AT1 receptors, where they are located and what happens when these receptors are stimulated. We discussed this in detail. We also discussed the pathophysiology of heart failure. We discussed how an increase in radius or left ventricular dilation led to a progressive decline in the pumping capacity of the heart with the help of the law of Laplace. Now, an ACE inhibitor would reduce the amount of angiotensin 2 available to bind to AT1 receptors in the vascular smooth muscle. This would lead to vasodilatation. Vasodilatation would cause a fall in the total peripheral resistance, a fall in preload and afterload. Administration of an ACE inhibitor would also reduce the amount of angiotensin 2 available to bind to AT1 receptors in the zona glomerulosa of the adrenal cortex. This would reduce the amount of aldosterone, and thereby this would reduce the preload even more. So, reduction of preload and afterload means a reduction in the diastolic wall stress and systolic wall stress respectively. And if we look at the law of Laplace over here, reduction in wall stress would mean a reduction in radius of the left ventricle, and we know that when the radius reduces, the tendency of the left ventricle to undergo dilation reduces. The cross section of the left ventricle slowly returns to its normal elliptical shape, and when this happens, the heart begins to move away from the law of Laplace and return to obey Frank-Starling's law. And when this happens, the cardiac output slowly increases. Now that's mechanism number 1 of ACE inhibitors in the management of heart failure. That's one way in which ACE inhibitors are beneficial in heart failure. Now vasodilators, wouldn't any vasodilator produce the effect that we just discussed? They cause vasodilatation, they would reduce the preload and afterload. So yes, vasodilators would produce this effect, but when we give a vasodilator, they reduce the blood pressure as well, and when the blood pressure falls, this is picked up by the baroreceptors present in the aortic arch and the carotid sinus, which would alert the vasomotor center, and the vasomotor center would increase the sympathetic nervous system activity and the RAS activity, which is not something that we want in the treatment of heart failure. The thing about ACE inhibitors is that they will reduce the amount of angiotensin II available to bind to AT1 receptors in the sympathetic nerve terminals and in the adrenal medulla, and therefore the reflex increase in sympathetic nervous activity is abolished. So this is what makes an ACE induced vasodilatation different from other vasodilators. ACE inhibitors do not cause reflex increase in sympathetic activity, unlike other vasodilators. This makes it ideal in the treatment of heart failure. So that's the first mechanism. Secondly, we know that prolonged and sustained stimulation of AT1 receptors leads to pathological remodeling, which causes a progressively lower contractility of the heart. When we give an ACE inhibitor, this phenomenon can be reduced, and therefore ACE inhibitors prolongs survival and reduces mortality. Thirdly, when we give an ACE inhibitor, it causes vasodilatation, and this causes renal vasodilatation as well. Renal blood flow increases, diuresis occurs, so you can call an ACE inhibitor an indirectly acting diuretic. This would further decrease the preload, and as we discussed earlier, the tendency for the left ventricle to dilate is reduced. It tends to return to its normal elliptical shape on a cut section, of course, and this would make it return to the Frank-Starling's ambit, and thereby the cardiac output increases more. Right, so let us try to separate this into mechanism number 1, 2 and 3. So this is mechanism number 1. ACE inhibitors cause vasodilatation. Ultimately, this causes the cross section of the heart to return to the normal elliptical shape. Frank-Starling's law becomes applicable once more. Gradual rise in cardiac output, mechanism number 1. And it achieves this without a reflex increase in sympathetic nervous system and RAS activity. Yes, mechanism number 1. Now, administration of an ACE inhibitor would prevent prolonged and sustained stimulation of the AT1 receptors, prevents cardiac remodeling, improves survival, mechanism number 2. And thirdly, ACE inhibitors will cause vasodilatation, increase the renal blood flow, reduce the preload even more, the cross section returns to normal elliptical shape, Frank-Starling law becomes more applicable, gradual rise in cardiac output, mechanism number 3. Right. So that was the mechanism of action of ACE inhibitors in heart failure. I have to stress that the mechanism of action of ACE inhibitors in other conditions are different. We just spoke about the mechanism of action of ACE inhibitors in heart failure, specifically in heart failure. It's interesting to note that the effect of ACE inhibitors on cardiac output is different in the presence and absence of heart failure. In the absence of heart failure, ACE inhibitors don't do much to the cardiac output. It remains more or less unchanged. But if the patient does have heart failure, ACE inhibitors will increase the cardiac output. Okay. Right, so unless contraindicated, ACE inhibitors should be given to all patients with impaired left ventricular systolic function, whether or not they have symptoms of overt heart failure, simply because we saw very clearly that ACE inhibitors prolong survival of the patient. It reduces mortality. Now, the situations where ACE inhibitors need to be abandoned and ARBs are to be used in their place. We saw that ACE inhibitors, or angiotensin converting enzyme rather, is responsible for the conversion of angiotensin 1 to angiotensin 2. If we were to administer an ACE inhibitor, this step would be inhibited. The thing is, ACE, angiotensin converting enzyme, is also responsible for the conversion of bradykinin to bradykinin degradation products. And if you were to administer an ACE inhibitor, this step would be blocked as well. And this would lead to an accumulation of bradykinin. And when bradykinin increases, this presents us with two consequences, both advantages and disadvantages. The advantage of having higher plasma concentrations of bradykinin is that bradykinin is a vasodilator, and therefore it would further reduce the preload and afterload. Unfortunately, bradykinin is also implicated in the higher incidence of cough and angioedema in patients receiving ACE inhibitors. So the incidence of cough and angioedema is less with the ARBs when compared to the ACE inhibitors, and in such situations, ARBs may be considered as alternatives to the ACE inhibitors. It is important for us to know the effects of ACE inhibitors on the kidneys. So let's try to break that down. Okay, so here's my attempt of representing the Bowman's capsule in the nephron. That would be the afferent arteriole, a branch of the renal artery. It breaks down into the glomerular capillaries, and there's the efferent arteriole. Now, okay, so in heart failure, the cardiac output is reduced, and therefore the blood flow in the periphery is rather sluggish, and this includes the blood flow to the kidney. So there's a fall in renal blood flow, which results in decreased renal perfusion. We also know that heart failure involves an increased activity of the renin-angiotensin-aldosterone system, and therefore there is a high plasma concentration of angiotensin 2. Angiotensin 2 binds to AT1 receptors, which are present in the efferent arteriole of the glomerulus, and this results in selective vasoconstriction of the efferent arteriole. And this helps to maintain urine output. Let's see what we mean by this. So, in heart failure, fall in renal blood flow, decreased renal perfusion, so there will be increase in renin-angiotensin-aldosterone activity, increased amount of angiotensin 2 available to bind to AT1 receptors in the efferent arteriole, causing selective vasoconstriction of the efferent arteriole, and therefore an increase in glomerular filtration pressures, maintaining the urine output. In this situation, in this context, if we were to administer a full therapeutic dose of ACE inhibitor, it would cause the inhibition of conversion of angiotensin 1 to angiotensin 2. There is no longer any angiotensin 2 which is available to bind to the AT1 receptors, and therefore this vasoconstrictive effect is lost. The glomerular filtration pressures are no longer maintained, and this could potentially precipitate an attack of an episode of acute renal failure. Due to this reason, abrupt initiation of full dose of ACE inhibitor could precipitate acute renal failure. For this reason, ACE inhibitors should be initiated at very low doses in patients with heart failure. Monitor the parameters like blood pressure, creatinine, and serum potassium, and if found to be normal, the dose of the ACE inhibitor may be increased slowly over a few weeks until full therapeutic doses are achieved. It's important to understand that when initiated in such a manner, ACE inhibitors do result in a fall in glomerular filtration pressure. However, the reduction is small and controlled. And when glomerular filtration pressures are reduced and the reduction is small and controlled reduction, the effect is protective. Small and controlled reductions in glomerular filtration pressures protect the kidneys from fibrotic degeneration. The effect is renoprotective. Right. What about the effect of ACE inhibitors in bilateral renal artery stenosis? Well, right off the bat, ACE inhibitors are absolutely contraindicated in patients with bilateral renal artery stenosis. We mentioned earlier that the afferent arteriole is a branch of the renal artery. So if this is a nephron on one kidney and this is the nephron on the other side of the kidney, on the opposite kidney, sorry, and this is the renal artery. In renal artery stenosis, this would be the picture. The renin-angiotensin-aldosterone system would be active, and as we discussed earlier, angiotensin II would bind to AT1 receptors on the efferent arteriole, causing selective vasoconstriction of the efferent arteriole, maintaining glomerular filtration. If we were to administer an ACE inhibitor to this patient, the angiotensin II mediated selective vasoconstriction of the efferent arteriole is lost, and we could precipitate acute renal failure in this patient. Okay, so ACE inhibitors are absolutely contraindicated in bilateral renal artery stenosis. Finally, regarding the AT1 receptor blockers or the ARBs. Now, for most practical purposes in terms of indications, contraindications and so on, ARBs are very similar to ACE inhibitors. We know that in heart failure, we initiate treatment with an ACE inhibitor, and if the patient develops a cough and or angioedema, we abandon the ACE inhibitor and we use an ARB instead, because the incidence of cough and angioedema is less with an ARB. Now, if an ACE inhibitor and ARB are similar in most respects, why do we start off with an ACE inhibitor and then abandon it if the patient can't tolerate it and go for an ARB? Why don't we go for an ARB straight away? Well, the reason is that there is greater evidence supporting the use of ACE inhibitors in terms of their efficacy in heart failure. ARBs have been found to be not as effective as ACE inhibitors in reducing mortality, rate of hospitalization, prevention of nephropathic progression, and so on. So it's always a better practice to start off with an ACE inhibitor, and if the patient can't tolerate it, then we abandon it and use an ARB instead. Only 3 ARBs have been extensively studied in the setting of heart failure with reduced ejection fraction. They include valsartan, losartan and candesartan, of which valsartan is the one which is used most extensively in clinical practice.